Welcome to the Burn Bootcamp podcast. I'm your host, Morgan Klein, co-founder and CEO, along with my husband and company visionary, Devin Klein.
And together, with our amazing team, we are going to help you push past your limits, not just physically in our gyms, but right here, mentally, emotionally, and spiritually on the Burn Bootcamp podcast.
Together, we will take on challenges and break through barriers to transform into the best possible version of ourselves. We are more than a gym. We are a community. Your community. Let's go, Burn Nation.
Hey, Burn Bootcamp Nation. Welcome back to the Burn Bootcamp podcast. Today, we have a guest interview. You all have been requesting that we bring more experts in on menopause, perimenopause. Today we have, and welcome to the podcast, Jackie Piasta. Jackie, welcome to the podcast today.
Hey, thanks so much for having me.
All right, I'm gonna do your intro because people got to know the credentials. Okay, they got to know the letters, they got to know all the things, and then we're gonna get right into it. Thanks for being here. Guys, listen, gals, Jackie is a board-certified women's health and gender-related nurse practitioner, a menopause specialist. She also hosts a podcast. We'll talk a little bit about that. And founder of Monarch Health, a midlife menopause clinic in Marietta, Georgia. We have a gym right next to you in Marietta, Georgia. We probably have some members that actually come to your gym in the first place, so that's cool. And I know that you've dedicated your career to advancing women's health with a focus on gynecology, menopause, metabolic health, obesity medicine, hormonal disorders, and just complex health and sexual disorders. All the things hormones. We're going to come to you today for, and we're really gonna go down a few different paths here today. So let me throw out some of these things. This is a lot of stuff, but we got to tell the people because we got to position you as the expert here. They have to know. It takes hard work to get all these letters. Okay, all right.
Oh my gosh, I know, the alphabet soup.
No, it takes hard work. So we gotta give credit where credit's due. The Menopause Society certified clinician, not only with the NAMS, but also the Medical Advisory Committee, okay, for the National Menopause Foundation. So I'm assuming these are boards in which you're influencing the narrative on menopause nationally, and so that's really cool. I would love to hear about those as we go through the podcast today. The Menopause Society, the Obesity Medicine Association, and the National Association of Nurse Practitioners in Women's Health, okay? So all these bodies you're involved with so at a very deep level, and then a co-chair of the Planning Committee for Menopause Summit, and on the Education Committee for the Menopause Society. So you're fully ingrained. You're in this world. This is your world, and we're happy to have you on today as an expert. The last thing that I'll say, guys, for those of you who are podcasters, obviously we have our YouTube audience too. Do you have your show on YouTube, Just Ask, or is it only on podcast?
No, we're just podcast.
Okay, so for all the podcasters, Just Ask podcast is where you can follow up with Jackie after this to learn more. Jackie, welcome. And I'm so excited to dive in today. So why did you get into menopause and women's health in the first place?
Yeah, this is so funny. It's a very long-winded story, so I'll kind of try to do it justice in a short amount of time. So my mom was a scientist in the infertility world, and I was the weird kid whose mom made test tube babies growing up, and so I knew I always wanted to do some sort of women's health, wanted to do fertility. My husband is an Air Force pilot, and he never took us to a place that was a large enough population to have that, so I fell into just OBGYN. And I fell into the menopause space, the women's hormone space. I actually was so desperate to get out of the house after having my second baby. And I took a job with a gynecologist who said, I do hormones. And I thought she was joking. I literally laughed at her in the interview. I don't even know why she hired me. And I was like, nobody does that. Nobody does women's hormones. It's not a thing. We weren't trained in, medical school, nurse practitioner school. We were not trained to really understand hormones outside of pregnancy and not getting pregnant. But the rest is history. And as you can tell by all of these boards and things that I'm involved in, I haven't looked back since. So
it must be an exciting world being on all those boards and being at the cutting edge of the sciences. When you think about where we're at today in society with women, menopause, perimenopause, and the newest kind of cutting edge approaches. Where are we at? Let's set a foundation for kind of where are we at versus where we were, and where do you think we're going?
Yeah, I think that's an amazing question. So what I kind of like to have a hopeful message. So we are getting places. We are making waves. We are getting loud. I mean, that's just kind of what we have to do. Jill Biden, the first lady, she was very helpful and pushing this narrative too, and bringing more money to studying women's health. And that's what we need. We need money to study things and to move the needle. We need people to get loud and people to push against the grain. In 2002, the largest of its kind study was published, or initial findings, which sort of ripped hormone therapy and the conversation around hormones and menopause out from under women's feet. And the initial findings of that study were that hormone therapy increased women's risk of breast cancer, cardiovascular disease, dementia, all the things. And so essentially overnight, women were left empty-handed, and the conversation completely halted. Medical schools stopped talking about this, stopped teaching it, and doctors and nurses, as an extension, sort of abandoned this part of health. Now, I would say within the last 5, maybe even 10 years, if we're being generous, I think women have woken up. Culturally, we're generationally not willing to put up with things. There's a lot of factors associated with this. I'm sure you as a gym owner can kind of see the changes in how women sort of want to live their life and the aging process, longevity. We're getting somewhere, but it's been in a cryo chamber for 20 years. So that's the biggest push on this, is women speaking up and saying, I need help, something's not right, and I'm not willing to stand for have a glass of wine and suck it up and you're just going to get fat and old.
Yeah. So when you talk about, Jill Biden, the first lady, really helping push this narrative in creating awareness around the importance of health in women, but menopausal health more specifically, was there any, was it just that narrative, or was there any institution, any legislation, any scientific mandate, anything that you can point to that says, okay, hey, no, the waves are, it's not just social media and people influencing to know more about this. It's actually coming from the top down in our country.
Mm-hmm, mm-hmm. So Jill Biden was part of the initiative on women's health research, which was $110 million allocated to the study of women's health and advancing research in the women's health space. Now, women's health space, that's incredibly broad, nuanced, and there's a lot of topics that fall under that. But we do know that a decent portion of that is going to be dedicated to menopause, because there is a lot of pull towards that subject in general. So that's probably, so yes, there's actual dollars being committed. There's actual committees being formed. There are people that are putting things together to hopefully push this along.
When the narrative obviously then educates us, what do you think was the biggest gap in education?
Oh gosh, I think the education itself. I mean, in 2002 and beyond, I mean, they've done studies. The Mayo Clinic did a huge study back in, oh gosh, I should have written this down, but maybe 2019, and it looked at whether or not residents, internal medicine residents, family medicine residents, and OBGYN residents. So if you're not familiar with the medical school training, residents are doctors that have graduated med school, and they're on to their respective training in their disciplines, and they're various lengths of times depending on the specialty. But they about 6% of residents in fields where we would expect the focus, to have a large ownership of the menopause discussion, reported feeling confident and comfortable discussing this topic with their patients. 6%. Mm-hmm. I mean, that's essentially nobody.
Right. Right.
So that's the data that we have. We are hoping. And when you talk to doctors that have been in the field for 30 plus years, they talk about the good old days where we actually did talk about menopause and hormone therapy. I would say it was upwards of 70+% that maybe felt confident and comfortable. Of course, I'm just coming out with that statistic, but it certainly wasn't 6%.
Right. So, yeah, that is interesting. That's quite a big jump. and $110 million toward research and toward development obviously helps that, and people like you help that. And I think it's really important because all of our members that have asked me about hormones, I knew nothing about hormones, or still relatively speaking don't, which is why you're here, right?
Yeah.
But I know that one of my jobs as the leader of Burn Nation, now we're 130,000 strong now, and one of my jobs is to help people clear through the clutter and really be introduced to both perspectives on any given topic, and have a real well-rounded 360 kind of approach to, let's in this case, hormones. And what percentage, I guess, of women that if you said, hey, you have testosterone, would actually agree with you? Like, do you think it's 0, 20, 50, 100%? Like,
I think most women, maybe upwards of 60%, would say, I do understand that women make and have testosterone. But if I told them that they make and have a significant percentage more testosterone than estrogen in their bodies, they actually make more, I would say less than 20% would know that.
That's interesting. Okay, so what is the relationship in the female body then to kind of testosterone and estrogen, and how does this life event, if that's a good way to put it, I'm not sure if that's the politically correct way to put it, but it's a big event that happens in people's lives, in women's lives, when they hit menopause. And my members come to me like, can you help me with this? I'm like, I can bring on Jackie, and she can help you, and she can help you with this. So what is that relationship? Yeah.
Well, let's just talk about it as men versus women first.
Okay.
And then we'll talk about in terms of women's bodies. So men have about 10 times more testosterone than women, but men also have estrogen. So we've gendered hormones. That's the first problem. And that's one of the issues with access to hormones as well, is that men don't assume they don't have estrogen, and women assume they don't make testosterone. So compared to men, women make 1/10 of the amount of testosterone. But compared to estrogen, prior to menopause, women make 3 to 4 times more testosterone in their body than they do estrogen. Mm-hmm. Your testosterone levels peak around the age of, late 20s, early 30s, and then you kind of get a subtle, slow, steady decline. A lot of people think it just kind of falls off the wagon, and it doesn't. You get a slow, steady decline of testosterone, and then it kind of levels out as you get towards menopause. Whereas in menopause, in perimenopause, which is the time leading up into menopause, women see vast fluctuations in their estrogen levels to an eventual almost complete or near complete loss of estrogen. And testosterone still stays a bit lower than what it was in your 30s, 20s and 30s, but it still stays. And then interestingly enough, we actually recently, a researcher in Australia named Dr. Susan Davis found out that women in their 70s actually have a peak of testosterone right around 70s, and we have absolutely no idea why. But we just observe that it's happening. So again, lots of testosterone, a lot more than we think we have. But it's an interesting conversation. It's a grehave question.
Yeah, it is an interesting conversation. I would assume I probably was like 27 or 28 before I realized I have estrogen as well. And, it is hormones are this elusive thing, I think, in most people's minds that are untrained, because it's kind of like the word enzyme. It's like, what is that? And how come there's so many of them, and how come they're in so many different places? If you were to just give us a metaphor, like a simple metaphor for what hormones are, what they do for the body, generally speaking, does anything come to your mind?
Oh gosh.
You know what I mean? Like an easy way to understand, so I'll talk about calories in the way that I approach it when I'm speaking to, somebody in what we call a focus meeting at Burn Boot Camp. We say that, most people don't know what a calorie is, right? They have heard the word, it's so familiar, but they don't actually really realize that a calorie is a unit of energy for the body made up of protein, carbohydrate, and fat. And so when you break it down that way, they're still like, okay, macronutrients. Okay, now you're gonna have to explain all these things, and we can just keep going down like the scientific rabbit hole. So I'm just like, calories are like gasoline for your car. It's very easy. It's very easy for people to understand that. It's energy to keep your vehicle going. You're putting poor gasoline in, you're putting diesel in a Ferrari engine, it's not going to go. And if you're putting premium fuel in a diesel truck, it's not going to go, right? And so do you have something like that for hormones that could help us easily understand it? Okay.
Sure, let's just like use your cell phone, because we're all in our cell phones all day, every day, right? So essentially a hormone is a chemical messenger, right? And so think of it like a text message, essentially. So you have your brain, or a gland or a specific area in your body which produces hormones, and it sends out a text message, and hopefully its aim is to meet the right recipient, and that recipient receives that text message and says, cool, I'm on it, let's go, let's do this thing, and it elicits whatever response that hormone was intending to elicit. If it meets the wrong recipient, or there's not enough of it, or the streams get crossed or whatever, then of course it elicits either no effect or a bad effect. We think about this a lot when we talk about insulin resistance, and when our cells no longer respond to insulin and we start storing more fat. I'm sure you talk a lot about this in your burn boot camps as our metabolisms change. But essentially it's a message. It's a message that's meant to have an effect on the body, and the target organ is what we want it to be hitting in order to elicit the effect that we want.
So when that effect is no longer taking place, meaning that the recipients on both ends of a message, something's broken, right? You're getting the little red iPhone. This didn't go through. Please try again later. What's happening with perimenopause and menopause in this kind of staying with this thread? What is the text message just not going through? Is it the recipient? What's going on?
Now my favorite analogy about menopause is it's your ovaries going out of business sale. And so essentially let's go back to the beginning. So dudes or not, dudes keep producing sperm every 72 hours basically until they die. Don't quote me, I'm not a urologist, but they essentially produce sperm every 72 hours for a very long time. Women are born with the exact amount of eggs that they will have, and there is a finite amount. And by the time we get to menopause, we have pretty much run out of those eggs. And essentially, that's kind of why I call menopause your ovaries going out of business sale. And perimenopause is sort of the start of that sale. And then menopause is when the stores have completely closed, their doors are done, and they're not open for business anymore. So the purpose, I guess, let's talk about reproduction. So there's many purposes of the ovaries, and we have yet to fully realize all the benefits that they have in our body, but let's do the basics of reproduction. The purpose of your menstrual cycle and your ovaries is to produce a state so that you can become pregnant if the timing and the alignment and the actions are correct. And so essentially when you get to menopause, it's the loss of your fertility and the phasing out of that. And so yes, the signals are not getting there because the ovaries become less and less responsive to the prodding. So the master person, the person sending the original text message, is the brain. It's a little area of the brain called the hypothalamus. And it sends a message to the ovary every month to say, hey, let's go. It's time to produce an egg to get ready to ovulate. And then eventually you have ovulation, and then you either get pregnant or you don't get pregnant. When the eggs are all gone and there's nothing left for the ovary to respond back and give the brain some feedback to say, yeah, I'm good, I got your message, we're getting this right, you get a loss of response there. And so your estrogen levels decline, progesterone levels decline, testosterone levels to a certain extent decline. And then eventually, once you get to menopause, you don't really have much responsiveness from a hormone perspective from your ovaries.
So as women, have you had people you've worked with that have been in perimenopause and don't know it and are mistaking the symptoms or maybe the feelings for other things? And what are those things? And how do you really identify? How would I know? How would I identify if I was going through this as a human?
Yeah, no, 100%. I think this answer is twofold, because we don't want to get to a place where we're pigeonholing everything into a menopause diagnosis, right? Or a perimenopause diagnosis, because that's sort of, we want to get away from this gaslighting women out of this experience in their own bodies, but we also don't want to sort of have a secondary gaslighting by just saying, oh no, everything you're experiencing is menopause, so let's do that, and we miss something. But a lot of women that come to me, there's a lot of things. We associate menopause and perimenopause with our periods stopping and hot flashes and night sweats, right? That's what we just have this image of this woman sweating and, sweating through her clothes. But what most women actually initially experience is a change in their mood, their overall demeanor. They become more irritable, more anxious, less able to roll with the punches, more fatigue, loss of sex drive, loss of libido. On your end, loss of stamina and endurance in the gym, or ability to feel like they can build lean muscle mass or lose weight like they used to, or maintain their body. We get brain fog, trouble with memory, concentration, loss of focus, changes in our menstrual cycles. Those are all things that we see way before a hot flash might even show up. And most women are wearing a lot of hats, and I'm sure you're married, right? Your wife wears a lot of hats, and so we're very good at taking care of a lot of other people except ourselves. And so I see a lot of women just kind of like putting up and allowing these things to pile up on their plate. And then I'm like, yeah, that's perimenopause. So it's a very vast, wide conversation.
Yeah, and it's one of those things that I would assume surprises people, even though it happens to everyone. Is that correct in saying? Yeah, it kind of catches you by surprise sometimes, I would assume.
Yeah, I think it's hard because there's a lot of things that can cause fatigue and weight gain and memory issues. I mean, these are not very specific symptoms. They can be vague, and we can sort of push them aside and ignore them for a while. But I have a lot of patients that feel very vindicated and validated when we start connecting the dots and things start clicking into place, and oh my God, okay, I'm not crazy, or I'm not, my body is not completely, turned against me. So I do find that this conversation, and a lot of it's driven by social media and outlets where women can actually connect and have a shared experience, is validating.
So I was on your Instagram, and which is very entertaining and informative, by the way.
Oh my
God! Yeah, it's good. It's good. You had this post, I think it was October 26th, and you talked about how women are 7 times more likely than men to be misdiagnosed during a heart attack, and I thought that would be an interesting question to ask.
Yeah.
Talk about that post.
So in order to talk about that post, we have to talk about the concept of hysteria.
Okay.
Are you familiar with that?
Educate us.
So hysteria is essentially the concept that all of women's problems originate in their head. And they're hysterical, right?
Okay. People? Is that people or women?
Women.
I could have hysteria. Could I have hysteria too? I think I've known some guys with hysteria now that you.
Okay. Well, cool. Well, the root word, or the Greek word for womb or uterus is hyster or hysteria, and so it stems from that it goes all the way back to the ancient Greeks, and the founder of modern of medicine, and the fact that women's ailments started in her womb, in her uterus, and then extrapolated to the brain. And so we are hysterical. We have hysteria. We're making things up. And what a lot of people don't understand is that the medical model is built on men. It wasn't even until 1993 where women were mandated to be involved in clinical trials. Prior to that, women were not mandated to be included in clinical trials for medications.
Just in 93?
Yes.
Wow, that's pretty recent. And before before that, you only had, I guess you're right. Yeah, that's crazy. I think we forget that sometimes. 93, I was 6 years old in 93.
I know. I was
That's
6 years
crazy.
old too.
Oh,
Yeah, but
nice.
it's the National Institutes of Health, the NIH's Revitalization Act of 1993, where it mandated that women had to be a part of clinical research trials. Prior to that, we studied primarily men, and we just anticipated. There's actually a PhD researcher out there. Her name's Stacy Sims. She's big into the health and wellness community and the muscle community, and she says women are not small men, and that's what we've sort of been clinically made out to be. Oh, we do the research on men, and then we'll just push it over and it'll apply to women. And so a lot of the model of how we have disease and illness presenting itself is that women will present like men. Well, men present with a heart attack with, chest pain and sweating, and it's a big bang kind of incident. Women have cardiovascular disease very differently than men. Men deposit very large plaques in their arteries. Women tend to deposit very soft little plaques all along their arteries. I kind of call it like little cookie crumbs. And so we have different symptoms of a heart attack. Well, if I'm a doctor or a nurse practitioner or physician's associate, and I've gone to my respective schooling, and I've learned that this is the way people present with a heart attack, if a woman comes through my ER with nausea, abdominal pain, other symptoms, I'm going to miss that.
Right.
So again, it's sad. We have a long way to go. I mean, 1993 was not a very long time ago, and we have a lot of catching up to do.
And so why is that? Because it seems pretty obvious that men and women, the one obvious marker is that women can give birth, and that's not the same. Let's just start there. Like, so how was it a byproduct of civil rights and like the hangover from that? What women's rights, that whole, like, was it part of the end of that era? That seems pretty late in the game to be like wrapping up equality for women. I guess you can make the argument that some things today even aren't still equality of opportunity. That's just a really interesting fact that in 1993 there had to be a mandate by the NIH to have its scientists. Which, by the way, for those that don't know the NIH, its output on pharmaceutical drugs is about the same output as, who is it? The big three: Johnson & Johnson, Pfizer. What's the third one? Moderna is their name, I think.
Yeah, Moderna.
Yeah, about the output of pharmaceutical drugs as those three companies combined, which is, I don't think a lot of people realize that. So. Yeah, that's crazy that the biggest institution in the world, essentially, for scientific research and pharmaceutical drugs, biological health, is 1993. I'm sorry, I'm sticking on that. It blows my mind.
I know. It's crazy. So it goes back to hormones. Women are too complicated to study. We have fluctuating hormones, and we complicate the data, and we have the ability to get pregnant. Nobody wants an unexpected or unintended pregnancy in the middle of their clinical trial. So men are easier to study for the nature of the fact that you don't have a menstrual cycle. So you don't have hormones that complicate things, and you can't get pregnant.
Did we actually believe that? Because that seems like a bunch of smart people believing in something pretty dumb.
I love that you think it is so simple. I think it is so simple too, but it also goes down to dollars, right? Politics and economics of things. And so these things all make clinical research more expensive. If we have to account for more variables, that means more time, more resources, more money. And so that's the long and short of it, unfortunately.
Very, very interesting. I'm gonna you know what I'm going to do after this is I'm going to go down a rabbit hole as soon as we get off on the 19. What was that act called again?
The Revitalization Act. The NIH.
The NIH Revitalization Act.
Yeah.
So interesting.
Yeah. No, it's really eye-opening when you start peeling back the layer of the onions on kind of how we've done things and why we do things and the reason behind it.
Yeah, it seems very silly. But then you kind of extrapolate that out into maybe a more abstract time frame, like 1,000 years at a time, and you like look back and it's very easy to see when you're looking at 1,000-year increments how incredibly good we have it now versus like 1,000 years ago when the entire, like, being a barbarian was like the same as
Yeah.
like being a banker. You know, it's
Yeah,
like it was
yeah.
just it was like a profession. You know, and so like 93 seems recent, but there's so much progress and infrastructure built
Yeah.
and value created to be able to do more studies. So I get the money thing. That's about the only thing that makes sense. But then the NIH, what's their budget every year? 80 to 100 million nowadays. So I don't know. It's just crazy. What board that you're involved with or body really worries about these things from the most macro view that you're able to tap into some of these cool things.
Yeah. So it was formerly called the North American Menopause Society, or NAMS. Now we call ourselves the Menopause Society. So that's the largest medical institution or society in the United States and North America that handles menopause and menopause research. And then the National Menopause Foundation, which I'm on the medical advisory committee for, and we are really focused on research and funding for menopause initiatives and driving that forward, education and all of that. So those are the biggest sort of entities or bodies that I belong to, I'm a part of, and have a voice in terms of trying to figure this stuff out and try to get more options out there for women, understand this better. But kind of like what you said, there's some debate on this statistic. But in 1900s, it was less than 5% of women lived past the age of 50. Mm-hmm. And now the average life expectancy of a person in the United States is over the age of 77. So we're living, and there's some controversy on that statistic because a lot of children died before the age of 5, and it wasn't until 1928 where penicillin was even discovered. So we were dying of infections and other things, and so it skewed that data a little bit. But we just have a lot more people living into a menopausal state, and most women are living about a third of their life, upwards of a third of their life, in a non-reproductive state or a low sexual hormone state. And because we're living longer, and because we're expecting, or we're needing to be more active for longer, I think women are starting to say, all right, I can't be 77 years old, and I don't want to be in a nursing home. I don't want to be a statistic. And so the conversations are starting to open up around, well, what can we do that actually improves our health span and not necessarily just our lifespan?
Mm-hmm. Yeah. Meaning the amount of years that you're living that you're healthy.
Correct. Right. Yeah.
Versus spending the last 5 to 10 years in a wheelchair or incapacitated due to like lack of taking care of yourself. Right.
Yeah. And I think a lot of us have seen, women tend to, historically and culturally be the large percentage of the caregivers in their family. And we've seen what has happened to the women in our family. I mean, this is our connection. So my grandmother actually, she was in a nursing home in Cornelius, North Carolina, right where you're
cool.
at, right in your backyard.
Yeah.
And, sadly enough, she was admitted in her mid-70s. And we asked when she went to the nursing home because nursing homes are not cheap. I don't know if you've ever looked into what it costs for a nursing home, but it's like minimum $6,000 a month to stay in a nursing home. And we asked, what is the typical course of this? And they said 2 years. And they said it so emphatically. And we were like, okay, what do you mean 2 years? They said 2 years. And would you not believe it? Would you not? She died almost 2 years to the dot of her stay in the nursing home of complications of what I believe are the disease processes of not having hormones and not having her menopause actively managed. She didn't maintain muscle mass. So she had dementia, she had hip fractures, she ultimately died of a stroke, which we know are all chronic disease states that are linked to menopause. And so that's why so many women are starting to wake up around their 30s, their late 30s, their their 40s, and their 50s and say, how do I not do that? Because I don't want that. If I'm going to live till 78, 75, 80, I want to be the grandma that's running 5Ks and 10Ks or going to burn boot camp, lifting the big weights, right?
That's right.
And not in a nursing home.
Right. And that's so important. And longevity is our key too. And I think that's why I was excited to speak with you today, because you're able to lay out the best options that we have right in our society to be able to manage effectively, so that you can increase the percentage of your health span in context to your lifespan, and try to live as many years as we can on this planet. This amazing, wonderful life we get, try to maximize the time we get to spend, the memories we get to make. And, we take nothing with us when we go beside our spirit and our memories. And I really believe that. And I think it's so important to do everything that we can to maximize how much time we get to spend in that health span that you mentioned. So do us a favor and lay out, for all the way from, I know there's HRTs, all the way to the preemptive care that you can be doing on your own, and everything in between.
Sure.
I really would like to hear, like, what's the spectrum of optionality, and as we consider managing effectively, what are some pitfalls to stay away from? What are some things that you should really lean into? I think that'll be a really great next conversation.
Yeah. So I always like to start the conversation with, what do you have control over without having to come into my office? And I think that's so important, because so much of the conversation right now is focused on pharmaceuticals and hormone therapy, which is completely my wheelhouse. I mean, that's what I spend all day, every day doing, is seeing patients for perimenopause and menopause and offering them and giving them the option of hormone therapy. But what can you do without seeing a clinician or a doctor or a nurse practitioner? And it's honestly foundational principles of health. So the 4 things that I try to teach my patients to do are focus on and direct their attention to: what is your sleep like? What is your nutrition like? How are you fueling your body? How are you recovering your body? How are you fueling your body? How are you pushing your body to new heights in terms of movement, if you want to call it exercise, whatever you want to call it, but movement? And how are you managing your stress? Those are the 4 non-negotiables, because there's no amount of hormone therapy that is going to make those things happen for you if your focus and your attention is not directed on making those better. So those are the big ones. We start losing, I talked about this earlier in our conversation, we start losing muscle mass at the age of 30. And if we're not actively trying to build muscle mass, we are losing it. So that's a really sobering statistic, I feel like, because muscle, there's a physician out there, her name's Dr. Gabrielle Lyon, and I love her quote. She says, muscle is the organ of longevity. 50% of women will sustain a hip fracture in their life. 25% of those individuals will have a fatal hip fracture or a health complication associated with that hip fracture and die within a year of their hip fracture. 25%. 1 in 4. It's crazy. So anything and everything you can do to prevent yourself from falling and breaking your hip, that is what you should focus on. Sleep is the way that we have to recover. The caveat to all of this is that a lot of times you can't do any of this if you're at adequate hormones in order to help. So my conversation always goes to the first line, most evidence-based, most effective, hands down, by a long shot, for treating menopausal symptoms is hormone therapy. We used to call it hormone replacement therapy. There's been some back and forth. Now we call it menopausal hormone therapy. Some people call it hormone therapy. Whatever you want to call it, MHT, HRT, HT. It's putting back the hormones into your body that you're losing with menopause. Not every woman needs hormones in menopause. Some women actually adapt to menopause really well. Some women, back to the conversation about research, we actually have very little idea of what happens to the ovaries after menopause. That's like a really big, like, aha, brain, mind blown moment. It's like we think one thing that women tell me all the time when they go have hysterectomies, which is the removal of their uterus, is, oh, my doctor's going to take my ovaries because I'm done with them anyways. They're no good anymore. And I challenge them with the narrative, do you actually know that? Because we actually don't know what's going on. Why can some women live into their 90s and do just fine without hormone therapy, and other women end up, like my grandmother, with massive health complications? So foundational health principles, first line, evidence-based, most effective treatment for the vast majority of women is menopausal hormone therapy. And that usually consists of an estrogen component. And if you have a uterus, and I would even vouch if you don't have a uterus, a progesterone component. Progesterone is active in your uterus. It helps to offset estrogen growth effects in the uterus, but progesterone also helps women sleep. It calms something called your GABAergic response in your brain, which is a calming pathway in your brain. So a lot of times women will wake up and they have night sweats and they have anxiety and they can't sleep and they can't get restful sleep and restorative sleep, and progesterone can really help with that. There's good science to back that up. And then sometimes for some women, we have the conversation about testosterone therapy as well. And we can talk more about that because I'm sure your audience wants that conversation. And then if you are somebody that is not a candidate for hormone therapy, which is a very small percentage of women who are not great candidates for hormone therapy as the first line option, or you're somebody who just doesn't want that for whatever your reasoning may be, we have a lot of different non-hormonal options, different medications. We can use antidepressants off-label. We can use, we have newer drugs coming out which work on a receptor site or a neuron in the brain, which targets your thermoregulatory center, which is essentially the thermostat in your body. And then we've got cognitive behavioral therapy. I know it sounds kind of crazy, but actually cognitive behavioral therapy has been shown to be very helpful in managing some of the symptoms of menopause, especially sleep disturbances. So yeah, that's kind of the buffet, if you will, of kind of how I go and approach treatment therapies for menopause and perimenopause.
Yeah, thank you for laying that out. When you are talking about the kind of newer sciences, the different, obviously, the evidence that this is new is the fact that the industry can't align on like a name, HRT. What is it? It's a newer thing. I think I'll take the position of somebody that's like super naturopathic. They don't want any needles going in. They don't want hormone. When you think about somebody, let's just say, I don't know, before 93, that's a date in here in our conversation today, in the 80s, lifespan wasn't much different. This stuff wasn't really available. Maybe it was, but at some point in the recent history, it hadn't been available. Without hormone replacement therapy, I hear CBT, that's one way too. But when you think about just the classic way to keep your hormones in check and in balance, you mentioned it, it's recovery, it's nutrition, it's strength training, a mix of strength and cardio, conditioning exercises, that will, allow your body to feel alive, to be stressed, and then to recover back into homeostasis. And homeostasis has, so when everything is all systems go, right?
Yeah.
So how much, I guess this is a long-winded way to set up a question, how much of what is normal? Like when you are somebody that is going through menopause and your ovaries stop producing estrogen and progesterone almost completely, how did our lifespan get that long without drugs? And what can people do if they didn't want to take hormone replacement therapy?
Yeah. So I don't know.
Does that make sense?
Yeah.
I was trying to get off the baseline of what normal would be as you go through this inevitable time, this event. You're living there a third of your life, like you said. Drugs always haven't been around. How have women managed this effectively before drugs? That's my question.
Well, I would answer you back as, do we know that they did? Or did we know that they didn't just soldier on and deal with it, right? Eventually, so to your comment on the homeostasis, right? So homeostasis is a concept of your body sort of calibrating itself back to a level, even playing field. A decent percent, okay, backing up even more. The average duration of symptoms in menopause is 5 to 7 years. That's the average if we're on a bell curve. Now, if we stretch the bell curve out longer, we can go 4 to 14 years as far as like what is the length of time that somebody is going to experience hormones. And it's probably kind of a 1/3 phenomena. Like 1/3 of individuals will not experience major symptoms associated with the menopause transition. 1/3 of women will have average duration 5 to 7 years or whatever that looks like, and then their body will eventually get back to kind of homeostasis to where they're not having hot flashes, sleep interruptions, and their body will recalibrate to this new normal. And then 1/3 of women will never calibrate to this new normal, and they will always, we call those patients the super flashers, where you would just have discombobulation urine forever and always. So I think back to your, how did women get through this before the advent of modern day pharmaceuticals? I think there probably was the 1/3 rule, just like there is today. Then we talk about, why are we living longer? Well, we're living longer because of modern medicine 2.0, basically medicine that happened after the advent of clean water, sanitation, antibiotics, and a systemized food system, so that we could, that sort of an issue. But again, to your question, like, not everybody is going to need hormone therapy. The problem is that we know that the data is very favorable for hormone therapy in terms of preventing bone loss, and we do not use it as first line. It's FDA approved for the treatment of hot flashes and night sweats, what we call vasomotor symptoms, osteoporosis, the prevention of osteoporosis, which is thinning or brittle bone syndrome, vaginal dryness, which is genitourinary syndrome of menopause, and then premature ovarian insufficiency, which is the loss of reproduction in your ovarian function prior to the age of 40. Those are the 4 things that hormone therapy is approved for. We do not use it specifically for primary prevention of cardiovascular disease and dementia, but we do know that the data shows that women that use hormone therapy in the right timing window have lower incidences of cardiovascular disease, better outcomes, dementia, cognitive decline, better outcomes. So I challenge my patients, and I always say, I wish I had a magic 8 ball. If you're sitting in front of me at 49 to 52 and you're saying, I am not massively symptomatic from a cultural standpoint, I'm not having 20 hot flashes a day and all of that, so I don't know if I should take hormone therapy. I will say, I do not have a magic 8 ball to tell you, are you going to be somebody that 20 years down the line didn't take hormone therapy and you're just fine and you're going to live to 101 years old and have a great health span? Or are you going to be somebody that has no hot flashes but really is going to be burdened by other issues associated with low estrogen stage, which is bone issues, all of those things we talked about with my grandmother earlier? So it's really hard. It's a very challenging conversation, because I have a lot of women coming into my office and they hear things on social media or podcasts or whatever, and they're like, I need hormone therapy. I need this. It's the holy grail. And it's not a panacea. That's why it's so important to incorporate a multidisciplinary approach into your life. Like, you can take as much testosterone as you want, but it's not going to build lean muscle mass unless you're going and you're lifting, you're doing big deadlifts and you're doing big Olympic lifts. It's not going to do that. So we cannot rely on hormone replacement therapy or hormone therapy, whatever we want to call it, to be this catch-all and this thing that's going to escort us to the finish line of life unscathed. It's just not. That's not the narrative we want to have. We want to have a more well-rounded narrative that encompasses all of these things.
Yeah, I appreciate that very much. I think there's a lot of one size fits all right now out there, and one of the jobs that I feel obligated to do, especially here on the podcast as it continues to grow, is to help people realize that there's outside of morality there's no such thing as absolutes, right? Like
Yeah.
the universe doesn't even have a straight, the closest thing to a straight line in universe is a light beam. Even ice that's frozen over, when you kind of zoom into it, it's full of air bubbles, and it's jagged at the microscopic level, and it's not all about jumping on like TRT or HRT, and that being the miracle drug, or people. The most notable one is the GLP-1s and the Ozempics and Wegovys of the world. It's like that stuff can work for sure, but it's always been about the underlying lifestyle. It's always been about what's made humans healthy and what's been in our control for as long as we can remember, which is moving our body, introducing ourselves to adaptation, to new stressors, picking heavy stuff up and putting it down, like you're saying, and recovering and sleeping well, and in putting great food into your body. And so on top of that, now modern day medicine and pharmaceuticals are, when used appropriately and used with a professional and a strategic plan, can be amazing. And I've seen it play out. One post I made a few months ago about there's a member of ours that had a gastric bypass surgery, and she had posted about it on her Instagram, and it got a ton of hate because people were like, oh, you're cheating and you're cutting it. It kind of like blew up in this like negative dark world of Instagram. I was like, oh, that's poor lady, because she's so nice. She had done everything necessary beforehand. She had 250 camps the year before. She had cleaned up her diet. Her diet was now a habit. It was habitual consumption of good, clean food. She had her mind right. She was getting, some therapies done. She was sleeping better. And then she went and got this surgery as just that cherry on top, that precautionary way to. She had been large and obese her entire life. And so it's just, to me, demonizing any one strategy or something is absolutely bad or something is absolutely good. It's always a combination of things. There's no such thing as a complex, like a simple strategy to a complex problem. There's a complex strategy that's involved when there's complex problems. And so I just appreciate you being objective and being in the middle and saying, hey, don't do this, yes, but like without these other elements of it, it doesn't work as well or at all, and vice versa. And that's what I think we need more of. And I'm on the front lines of health traditionally. You're more in like the back lines of health traditionally. And I think we need to come together as a front line. The same way you're seeing patients every day after they have a problem, I'm seeing patients every day before they have one, or at least they're trying to stave off any problems. And if we can get more proactive and start to, one of my missions at Burn is to be more involved in academia, be more involved in the science as we evolve and we scale as our approach, because I think we're big enough now, and I'm young enough, I have enough runway to where we can really do some damage in terms of the global health narrative, similar to what you're doing and what you're talking about. It's just like
100%.
The neutrality of it all is very important, to start from that axiom when everyone out there is trying to pull you into like this one obscure way to do one thing, and if you don't do it, you're gonna die soon. It's like, what?
Well, I mean, you have to think of it like, you don't walk into your gym every day and say, okay, I'm only allowed to use the 20-pound kettlebell, and that's all I'm allowed to use today. Like, That's ridiculous. We don't like roll up to Home Depot and say we have 5 minutes to go pick out one tool to build an entire house. That's ridiculous. It's absurd. And I think that social media and a lot of these narratives only lend themselves to these sound bites of little cookie crumbs of information. And it's within that co-creation of an individualized plan for the individual between a multidisciplinary team that really is where the good stuff happens, right? Because just like your person that had the bariatric surgery, she had an entire story that there was so much more to that conversation. It's so easy to pick something apart and put your opinion in, and the volatility of some of these spaces that we are in. But I think it's really again, it's not an all or nothing. It's way more of an and conversation than an or conversation.
Yeah, I agree. I agree definitely. Jackie, listen, this has been an amazing conversation. We're almost at time here.
Yeah.
What are some parting words for the audience? Maybe give me a combination of all kind of the best advice that you've given to your patients
Yeah.
over the time, and try to kind of bottle that up into a couple minutes for the audience as we wrap up here.
Sure, sure. I think there's obviously there's different viewpoints on. I always ask my patients like, how do you view menopause? How do you view perimenopause in this transition in your life? Do you view it positively, negatively, neutral? What does that look like for you? Because I think it's really important for us to kind of assess and introspect on what this time in our life looks like. And then when we look at that and we look at the narrative behind that, really kind of focusing in on ourselves and what can I do at this time in my life to really empower myself to move forward, and start working and focusing on myself. So much of a woman's life before menopause and perimenopause is focused on so many other things: career, children, spouses, whatever you want to land on that. And so it's really a time of to sort of pan out and then pan back in. What can I do today to really love on myself and put my best foot forward? With that being said, I think it is so important to build a team around you, that we don't have to do this alone. We do not have to do this by ourselves. So we know that, again, and it's kind of controversial, but there's a concept around blue zones, which has like the highest concentrations of people that live to 100 or greater. And we know that one of the most common things that they find is community. And I think that's one of the things that you build at Burn is community. When we have community around us and people to lean on and have that shared experience with, so important. It's so important in menopause and perimenopause. So finding your people, finding your tribe, finding your team, whether that's clinical or non-clinical, whatever that is, combining you and me and our different disciplines and our colleagues around us and their other respective disciplines, and really figuring out what is going to be, like I said, that creation of what your menopause transition looks like for you. And so that's my advice, is to really think about that, because you don't have to go through this alone. There's so many people out there that are so eager to build this with you.
Well, I'm excited to have a new wave of medical professionals such as yourself who are including the foundational, in our control, biological mechanisms like working out, eating well, sleeping well. I'm so glad and refreshed to hear you incorporate these into, well, otherwise an industry that doesn't necessarily look at those things as a significant part of anyone's health plan. But yes, it is a combination of both, in my opinion, first going internally, looking inside for the solutions, and being able to get your mindset right, the set of your mind, really to establish belief systems that are empowering, and to work with someone to, or on your own to disintegrate or unwind belief systems that don't empower you. And that's where the work starts. And then once you've done that work, and you're going to continue to do that, it's just called building character. People like to glorify it or make it seem all mystic. It's just called building character. It's introducing yourself like an exercise routine to hard things, and so that you can become a person that does hard things. And so be that person, and then use the society that's around us and this amazing technology in medicine to be able to enhance who you already are, not to try to build yourself from the ground up. You got to do that hard work mentally, emotionally, physically, and just like that's the meat and that's the potatoes, and then we have the best, although there's problems with it, and hopefully over the coming years we'll clean some of it up. But we have the best medical and pharmaceutical system in the world. It has a lot of flaws, like I said, but it is still the best. And look at our lifespan, and look how crazy more healthy we are from like 100 years ago or 200 years ago, and just put that into perspective. Yes, do we need to clean up? Yes, is there scientists out there getting royalties that are working on drugs? Yes, and we need to get all of those, find all of those areas of potential destabilization of the system and go clean it up. And I hope that we do that. But that's in every industry. That's not just medicine. And so, I just speaking out loud to end the podcast here. It's just been a great conversation. You're a great conversationalist. I loved talking with you. And we can check Jackie out, guys, on Instagram. All right, you have Jackie P _ GYNNP on IG.
Yep.
Got it. All right, and then we have mymonarchhealthco.com as your website if people would like to follow up with you more. And I think there's a lot more that we can uncover. We just kind of touched the tip of the iceberg here in an hour and some change.
Oh my gosh, there's so much of a conversation here, 100%. I think we did a good job.
Yeah, we got through a lot in an hour. So I'd be happy to speak with you again, and look out for the Just Ask podcast on Apple. And are you on Spotify for that?
Yep.
All right, Apple, Spotify, guys, check it out. Appreciate you, Jackie. Thanks for being here.
Thanks for having me.
2 claps on 2, everybody. 1, 2.